Other cases, just showing some cases. This is not one of my cases, but it was referred to me. As you can see, one of the dentists, because of the treatment planning, improper treatment planning, improper analyzing of the occlusal scheme itself, the doctor placed 2 implants, one in the tuberosity and one was placed actually in the crest of the bone. Apparently, what was told to me that it was a closed sinus elevation technique, and it ended up, you can see where the implant upside down inside the sinus, almost towards the orbit, which in such cases I had to remove the implant from the sinus and replace bone and membrane and place the implant again. It's very important, of course, in cases of sinus elevations to take CTs and use the new cone beam technology to plan properly the amount of bone that you have, and from a buccal-palatal aspect and a mediolateral aspect. As you can see, this is another case just showing you again, not how to do sinus elevations, but again showing you that even when we have complications in cases of sinus elevations, like in this case, basically this case, she had wanted to place implants, but she had pneumatized sinus, so sinus elevation open technique was attempted first, and then when the window was opened, the lateral window was opened, the Schneiderian membrane was very, very, very thin, that from the first touch of the elevator to elevate it, it just ruptured completely, and I had to place a collagen membrane inside and close the gums and abort the surgery. And the patient came back after 6 months, and this is after 6 months. You can see that we have one of the implants placed here was a closed sinus elevation at the beginning, which was stable, and now it was integrated, now re-entering the same surgical site that was done before. And as you can see, using the same old technique of using the round burr, the large round diamond burr, to open what was open before and attempt to re-elevate the newly regenerated membrane of the sinus again. You can see the amount of fibrous tissue which was actually generated on the ruptured Schneiderian membrane. You can see that again some bone has been regenerated again from the previous open lateral window that was done before. Again, the whole idea is to show this, that the amount of complications that we can realize and can occur during this very technique sensitive procedure can be overcome if you know what you're doing. But the most important thing is, after doing this, is the right loading of the case and knowing the right biomechanical principles of loading. You can see in the same case again, after re-elevating, you can see 1, 2, and 3 perforations. But when we have perforations, we all know that there is no problem, as we know after elevating we can just place a collagen membrane inside to fix this perforation. Using the surgical guide to exactly place my implants, I had placed 1 implant before, which is integrated. Now I'm placing the other 2 implants, which are going to be splinted together, putting in mind again the tripoding of these implants according to the waxed up cast which the surgical guide was fabricated from. You can see how these drilling, if you look at these osteotomy sites in relation to the first implant and connect them together, they are tripoded. Again, a collagen membrane, in this case I use a Biomechanical collagen membrane to place the membrane itself. As you can see, there is the 3 perforations, and then placing the collagen membrane to fix these perforations, and then placing the implants, you can see, and then placing the bone itself inside to continue. But what you can see here is again the 3 implants that were placed They are tripoded. Maybe you can see the cover screw of the middle one is a large cover screw. The whole idea is to get more stability by ledging this cover screw on the remaining bone around it. And they are tripoded. And again, the implant systems had micro screw designs to engage more contact, increase the surface area contact of the bone around these implants. And then placing the membrane to close the window, the normal classical procedure itself. And this is the same case, and the patient chose that afterwards that we remove most of the teeth because they were predominantly affected, and place more implants and connect all the implants together and splint them together to counteract any detrimental lateral forces itself. Now again, coming back to biomechanical considerations in implant orthodontics in particular, we have to know the implant positioning. How do we position the implants? What is the AP spread? The AP spread stands for the anteroposterior spread or distribution of implants along the arch of the ridge, crossing the midline. Whenever we're planning to place implants crossing the midline, we have to put in consideration to put it in a more curvilinear arrangement rather than, like on the other slide here, a linear arrangement. Because whenever we have implants crossing the midline and we have it in a curved distribution, as you can see, any three implants connected together, they create a tripod, because every middle implant is an offset implant from the other two. And therefore any tilting or torque or any cantilever forces on your implant restoration will be counteracted by this offset implant itself, in relation or comparison to cases where we have to place the implants in a straight line, like in cases of a square shaped arch, or whenever we're placing 3 or 4 implants in a unilateral position, like the previous case in sinus elevation, we try to place one of the implants out of the straight line to create the tripod itself, to counteract any forces. As you can see, again, tripoding. So this is from the stress and strain analysis, as we said before, which was found out that by placing the implant and applying forces, it was found that most of the stress and strain was actually concentrated in the first 3 millimeters of the implants from the crest of the ridge, while the remaining forces starts to fade away around 7 to 9 millimeters, which gives the concept that we don't really need to use long implants whenever there's bone available, because actually whenever you're just placing longer implants because you have more bone, you're actually killing living tissue. You're creating a dead space itself. And since from the literature and the studies, this stress and strain photoelastic analysis shows us that after 9 to 10 millimeters we don't have any loads, so why place more longer implants and creating more dead spaces than living tissue? The only time that I place longer implants, as everybody knows, is when we're doing immediate extraction and immediate placement of implant, where we are dictated by the length of the socket itself to place a longer implant to get immediate stabilization of the implant in bone itself. Again, other cases where placing implants, cantilevering them, placing shorter implants because there is pneumatization of the sinus and the patient didn't want to do sinus, the doctor doesn't do sinus elevation. What happens at the end, after several years of loading, you can see what happens, failure of the whole restoration itself. This is diving in the Red Sea, and you can see the hammerhead shark here. Going back to our topic, again showing that in complications of sinus elevations it still can be handled, whether, as I showed you in the previous cases, that we can place a membrane to fix the perforation, of course depending on the amount or the size of the perforation of the Schneiderian membrane, In very few cases I did suture the perforated, because the size of the perforation in the membrane was very large. I actually sutured it, which is very hard technique, and I wouldn't try to do it actually, because you might just end up by perforating and cutting the whole membrane and then placing the collagen membrane again. As you can see, just showing that again, complications, if it's done in a proper scientifically based manner, it can be overcome. But if the treatment plan of your implant restoration to function future-wise under normal occlusal loading, if it's not properly planned, you will get failures of everything that you have succeeded from the beginning. So again, other cases, just showing that after placing the implants, placing more implants, connecting all the implants together in a curvilinear arrangement. As you can see, every 3 implants are creating an offset implant to counteract any lateral forces, as we said before, and the end product, you have a successful long-term implant restoration. Implant positioning again. From the literature, we know that crown height space is a very important, significant factor in implant itself. What is the crown height space? The crown height space is actually the space available not just for the crown, it's from the crest of the ridge around the implant to the occlusal table of your same implant restoration. What is it significant? Because whenever this crown height space increases, it increases what we call a vertical cantilever. And whether this vertical cantilever on the implant increases, we have more stresses on the bone surrounding the implant itself. Again, cases where we have an extracted tooth, the normal pattern of resorption, the normal physiologic pattern of resorption is usually from the buccal towards the palatal or towards the lingual. And yet, if we don't have proper planning, what happens? We tend to place our implants where the bone is available. So when the bone is available, we'll tend to place it more towards a lingual pattern. But when we tend to place it more towards the lingual, and then we place a normal crown on the implant, according to the opposing occlusion, what happens? That the buccal part of your implant crown becomes more bulkier. And since it becomes more bulkier, to overcome the amount of resorption in a buccal pattern, this is more of a cantilever on your implant restoration. So in other words, we have to place our implants in the right position according to occlusion and not according where the bone availability is. As you can see, this is one of the cases with sinus elevation and the end result in the normal occlusal. So the significance of crown height space, as I was talking before, whenever there is an increase in crown height space, the vertical cantilever is increased. The amount of forces on the crestal bone is increased. You get more bone loss. Whenever you get more bone loss, again the crown height space increases, and it becomes a cycle, ending up with bending forces on the entire implant supported assembly itself. And what happens? You get screw loosening, bone loss, implant fractures, ailing implants, and failing implants at the end. So in other words, an increase in the crown height space is directly related to the increase in the biomechanical forces itself, and you get all the failures that was shown before. So again, coming back to the same photoelastic stress and strain analysis, we cannot consider the same rule of crown root ratio like implant crown ratio. Most of the forces again on the implant is concentrated between 7 to 9 millimeters from the crest. Crown height implant ratio, as I said, cannot be taken into consideration like crown root ratio as in conventional prosthodontics. So in other case, increase in crown height space requires more numbers of implants and not longer implants. Occlusal design, again from an implant prosthodontic concept. Whenever we are placing crowns on implants, we don't want these high cuspal inclinations and steep cuspal inclinations. We don't want these grooves, because all these inclinations actually tend to create a more shearing forces and lateral forces from the normal occlusal forces. So what do? We tend to try to narrow the occlusal table, as you can see, from a buccolingual dimension, so you don't get any cantilever forces on a buccal or a lingual perspective. And these steep angulations and steep inclinations of the cusps are reduced to become more shallower, so whenever there is any forces on these inclinations, they do not become harmful forces or lateral detrimental forces, as you can see. Again, from the literature, we know that in natural dentition the occlusal surface are either enamel or comparable restorative material, while shock absorption is achieved by periodontal ligaments. Reversing this arrangement will result in reduced chewing efficiency and increased biting forces. Again, from another Japanese group literature, we can see that resident teeth should be selected when the primary requirement of artificial teeth is the high shock absorption ability, while porcelain teeth is selected when the primary requirement is high masticatory efficiency. So in other words, occlusal material in implant prosthodontics should be selected to increase the masticatory efficiency itself, and thereby reducing the biting forces itself. We all know that the impact forces on implants are much higher than on natural teeth, basically, as we said, because natural teeth have their normal phenomena of proprioception and the presence of periodontal ligaments that tend to give the teeth some kind of shock absorption, while the intimate contact of implants to the bone itself, they don't have this phenomenon. And yet we all find that we have fractures of the porcelain restorations on natural teeth. As you can see, this case was actually a 3-unit bridge on 2 implants, and the patient was a high grinder after doing the 3-unit bridge. From the previous slide you saw that there was a fracture from the porcelain because this patient was a bruxer. So initially we removed the 3-unit bridge and reconstructed a porcelain fused to gold bridge with the occlusal aspect all in metal or gold. So in other words, whenever possible, to make the occlusal anatomy of a metal surface or a gold, it's much better for 2 reasons. You don't get fractures, and number 2, at the same time you have some kind of malleability that the forces can be absorbed more on gold. Whenever possible, again, such cases, most of the implant cases, I try to give some kind of an occlusal protective mean as night guards, because again the patient tends to grind and clinch on implants and they don't have any proprioception, so they don't really know the amount of impact forces on the implants. Even if I had to reline this night guard with a soft tissue reline material in the area of the implant itself. And these are some of my mentors that I have to thank for what I've been doing. And as I said, I have a lot of friends coming to my center, and I really would like to thank everybody in Dental XP for the great work they are doing. And I hope you enjoyed this lecture. These are my residents in Milan University. They are the peri residents, which I go and give actually prosthodontics. And this is my team back in my institute, which we work together. And I really thank you for listening to this lecture. Thank you very much.